So I am going to now introduce you to our board chair, the committee chair, the man who does it all, and my right arm here at the Lung Association, Alan Wentworth.
Thank you very much. See, all the giveaways are up here in the front of the room. We got a lot coming for you. So, and please do see the exhibitors. They're the reasons we can make this event happen, is also Rick Hurley and the Smith family. So I'd like to introduce our first guest. Dr. Hunt is an esteemed member of the Critical Care Pulmonary Consultants team based in Greenwood Village, Colorado. He currently serves as the president-elect for HCA Medical Executive Committee at HCA Health One Skyridge Medical Center. He is a committee member on the President's Council within the HCA Continental Division. Dr. Hunt holds the position of Vice President for the CCPC and is a core teaching faculty for Skyridge Internal Medicine Residency Program. His roles include physician advisor on the National Respiratory Care Advisory Council for SkyOn Health, and pulmonary medical director at Kindred of Aurora. He's been dedicated pulmonary critical care, neurocritical care, and internist specialist at CCPC since 2000, specializing in pulmonary hypertension, pulmonary embolism, lung cancer, bronchoscopy, including robotic navigational bronchoscopy. Please welcome our esteemed speaker, Dr. Hunt.
I think I have it. Thank you, Al. Appreciate it. Can everybody hear me? Is that working? All right. Well, thank you very much, and I really appreciate this invite. I'm honored to be here and to speak with you all. Just a quick disclaimer. It was a busy night in the ICU, so if I go into a fugue state, don't worry, I'll come out of it in a second. couple cups of coffee is a good thing. So today I wanted to speak with you guys about something that I teach my residents and my medical students about, because I think it's something that is often misunderstood, which is dyspnea, and the link between how your heart and your lung function is working in your body, and how, when it's not working so well, that translates into this sensation. So the first thing is we always have conflicts of interest. So this is I am a lung doctor at a lung conference, and so Chuck Norris is an attorney representing injured people, sort of thing. So it is not really a conflict of interest, but I don't really have any, I'm not on any sort of drug panels or have grants or things like that. I'm in private practice. I came out here and trained at National Jewish many years ago, and then went into private practice after that. And I think kind of went through most of the other things that I do in the community here. So again, I want us to talk about dyspnea. I want us to define that first. And it's going to be a little bit of a nerdy talk, so I apologize for that. That's how I am about the lungs. We're going to talk about what that sort of physiology or pathophysiology is for you guys and what causes it. And then the last part of the talk is, I think, going to be sort of the nuts and bolts about how we as doctors look at testing folks that come to us with shortness of breath or dyspnea, and then how we help folks in rehab or treat it. So let's talk about, this is the way I like to think about it, and I usually try to use analogies because I find it a useful way to think of things. So when we're breathing, we're like an internal combustion engine, right? So we are just like that car there on the right. We intake air, right? We have fuel, we have glucose or fatty acids or all these other things in our body. And then we have a pump, right? Just like a fuel pump or like those cylinders in the car that's taking that fuel, taking that air, and then feeding it to the rest of our machine, our body, right? And so here you can see, just like that intake here, we've got our lungs up here, and what's taken, of course, that deoxygenated blood, getting it oxygenated again, sending it back to the heart on that left side of the heart, that pumps it out to the body, goes through the body, gets, gives out all its nutrients, all its oxygen, and then comes back and goes to the right side of the heart, kind of fills that up, and then back out again. And I always like to point out to all my patients in pulmonary hypertension that, pulmonary hypertension is high blood pressure over here, and this is a single system, right? So as much blood as your whole body sees over here, right? With each squeeze of your heart, your lungs see that amount of blood flow, right? So just right here in your lungs, you're seeing as much blood flow with each squeeze of your heart as your whole body combined. So I always think that's kind of amazing. And I always just think the lungs are an amazing organ. So we'll talk more about that. But I think this is a useful analogy, is that we're like a motor, we're like a car, and we're taking in air, we've got our fuel, we've got our pumps, we've got all that together, and then dyspnea is when that car is backfiring, or it's just not, we're not getting the power out of it that we want, right? And so I think in popular culture and things like that, right, there's some images of what dyspnea looks like. And I picked these up, off of a couple of my favorite cartoons. We often think of, or at least when you see it in a cartoon, right, it's somebody who's exerting themselves. In this case, these two gentlemen are a bit heavier, and they're trying to run or do something, and they're getting short of breath, and they have to rest and take a breather. But there's other really big things in this world that can do amazing things, hold their breath for 45 minutes, way larger than these two cartoon characters, right? And they don't have any dyspnea, right? So there's a lot actually to start to unpack, I think, when we start to talk about dyspnea and what causes it, how we as individuals experience it, and then what we can do about it. Okay? So let's talk about a definition then. So this comes from the American Thoracic Society, or ATS, and this is their definition that they used since 2012. A subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So that's kind of a lot to unpack, and basically what they're saying is it's subjective, right? So it's something we feel. We may have different scales, like Borg scales, things, little, if you have ever taken a walk with a medical assistant or a nurse or whatnot, and they're asking you about your shortness of breath, and they're asking you to rate it, so that we try to get quantitative with it, but it is subjective at the end of the day, and it's a breathing discomfort, and they're qualitatively distinct sensations. What does that mean? That means that we all can kind of describe it a little bit differently or feel it a little bit differently. It's not a single, descriptor of chest tightness, or I just can't get, I can't get the breath that I want, or I feel like my oxygen's low, or things like that. So we all feel that kind of differently, and we feel it in varying intensities, right? So a lot of really interesting physiology has been done over the years, looking at folks who have similar lung issues going on, but feel very differently in terms of how they experience dyspnea. But I think that's that's a very wordy definition, and I think this is just a simpler, more straightforward one. It's an uncomfortable awareness of breathing, right? So that's what dyspnea is. We're all breathing all the time. Most of the time we're not thinking about it, but when we start to think about it and when we feel it and when we're feeling some sort of sensation that we don't like, that's dyspnea. So this is a little quiz that I like to give my residents when I talk to them about dyspnea or shortness of breath, and when they're kind of interviewing patients coming into the ICU, or maybe up on the floors in our pulmonary clinic, that sort of thing. And so I wanted to do just sort of a raise of hands here in a minute. I'll go through this little list, and I'm going to ask you guys, which one do you think is the biggest deal for dyspnea, really? Okay, which one of these four things is the most noticeable to most folks? So the first one is low oxygen, right? So that's when you've got your SAT monitor, and normally we're 94, 96%, or maybe 90, 92 is okay too. But once you're in the below that 88, 89%, then we start talking about needing oxygen and starting that. So it's low oxygen saturations. The next is that high carbon dioxide, right? So that's that CO2. That's the exhaust pipe of our engine, right? That's the we burned the fuel, we brought the oxygen in, and now we need to exhale what we've produced, which is that CO2. And in many different lung diseases that can, or other problems in the body, that CO2 can rise in your bloodstream, and can that cause dyspnea? A soccer ball to the stomach, that's a callback to when you were a kid. Or cardiac ischemia, right? So when you might not be having a full-blown heart attack or anything like that, but you're having maybe this tightness in the chest or things like that from a low blood flow to the heart, okay? So all of these things can cause some shortness of breath and whatnot, but which one's the biggest deal? So like which one will cause the most dyspnea in most folks? So let's just do a show of hands. So who would say, we'll go from bottom to top. So who says the cardiac issue? So, just a little bit of a tightness in the blood flow to the heart. Don't be shy. All right. How about the soccer ball to the stomach? Okay. How about the high carbon dioxide? Very good. All right. And then how about the low O2? All right. This worked out perfectly. All right. So we'll go through this now, and we'll start to unpack this. All right. So let's talk about, and now, and of course I'm a pulmonologist, so you didn't take the bait about the cardiac issue, right? So anyway, but we'll go through all that. So pulmonary causes of dyspnea. This is an older slide that I took, but I think it's helpful. I've got a couple similar slides coming up that sort of just unpack this. But I want us to talk about, from again, a nerdy standpoint in our bodies, how we experience, what those inputs and outputs are, and what makes up dyspnea. There's been a lot of study into this. So you can see here we've got our respiratory muscles in the bottom middle, right? Those are our lungs. This is our respiratory, kind of our bellows, right? So we've got muscles in our chest. Our diaphragm is the most important, but then you've got all those what we call intercostals, and then we've got these supraclavicular muscles and scalenes and things like that up in our neck that are all able to help us breathe. So that's our bellows. And then to the side you can see, you've got on the left, you've got those chemoreceptors, right? So that's that low oxygen, right? So we have receptors in our blood vessels, we have receptors in our brains that are figuring out, they're testing, little oil sticks to test the water, so to speak, of how low our oxygen is at times, or how high our CO2 is at times, and tells us how to breathe. And then we've got these mechanoreceptors. I think these are really cool. These are J receptors, are called, but basically these are like these little receptors in our chest, in our muscles, in our lungs, that are giving us feedback when we stretch our chest, when we take that deep breath in. They're sending signals back like, hey, I'm stretching this much, or I'm feeling this much tension, or I'm working this hard, and they send that back to our brain, okay? And then we've got this respiratory center that's back here, and I'll show that on the next slide. But we've got a little center in our brain that tells us how to breathe. This is what takes over for us when we're not thinking about it, right? This is how, it tells us to start increasing our breathing when we're going to go for a walk or exert ourselves somehow. And then we have that brain cortex. I always say this is that big part of the brain up on top. This is what makes us us. This does all our thinking and our feeling. And this is what perceives those signals, our dyspnea. So here's a little bit better graphic out of a New England Journal, but just to kind of show a picture to that, right? So you've got all these mechanisms down here, all these mechanics that are kind of telling us how big our lungs are stretching, how much we're moving things down here when we're taking a deep breath in. We've got our airway up here, and then we've got our brain, and the big part that's actually doing all the feeling and thinking for us is up here. The medulla, which is the automatic part, is down here. Then we've got all these arrows going everywhere. We've got sensors, we're basically, our brain is saying, take this much breath, and then we have all these things that come back. Our CO2 is this, our O2 is this, and our chest is this big. And it's all kind of coming together. And so when you look at it all then, this is how we get these feelings of dyspnea. And what are the most important factors? These have been really looked at very closely. And oxygen is the least important, okay? So this is always fascinating. And what inspired me to give this talk today is that is really COVID, actually. Because COVID for me, COVID was many things, right? But as a lung doctor, like I said, as a nerd about lungs and about lung physiology, I thought it was fascinating seeing patients come in and see me who had saturations, and this was very classic. Their saturations were 80, 82%, 78%, somewhere even like 68, 70%. And they'd say, "Doc, I feel fine. Like it's no big deal, Doc." And here they are, they're coming into the hospital, and we're about to put them in the ICU. And they don't feel that bad. And so that's just a very real, visceral example of how little our bodies think about oxygen that way, right? How little that oxygen goes up to that cortex, goes up and makes us feel like we're short of breath. And it kind of drives me crazy sometimes too, because sometimes, I sometimes hear staff trying to reassure patients like, your oxygen's okay, your oxygen's okay. I don't want to, sort of muddy the waters too much and all that, but I always think, gosh, it's not their oxygen that's the problem. They have other issues why they feel short of breath, right? Your oxygen can be 95%, you're doing great, and you feel short of breath because oxygen has very little to do with the way you're feeling, all right? Now, don't get me wrong. You want it good, you want it normal, you want to wear your oxygen. It's very important for all kinds of other reasons. What I'm talking about is that sensation that you feel, though. And oxygen often has, in many people, most folks, it has a relatively small portion to play, okay? The next thing you guys mentioned was CO2. CO2 has a bigger portion to play. It definitely does. CO2, though, takes a long time. It's a very slow mechanism. To give you an example, so when we're in the ICU and we need to test whether somebody's brain is functioning, whether they're going to breathe very well on their own, right? We might do a very special test where we make sure their oxygen is good, they're on a ventilator, but we stop the ventilator and we check their blood gases, right? And what we're really looking for is about a 25% rise in CO2 over 10 minutes. So they're oxygenating fine, their heart's pumping great, all of that. We're just not ventilating. We're not moving the air for them. We're letting them do that on their own. And if their brain is working, their CO2 is not going to go up. But if it's not, it will go up by about 25% or from like 40 to 50 over 10 minutes. That's not a really great system for our bodies to know how we're breathing then. It does contribute more to that feeling of dyspnea than the oxygen, right? It definitely does. But if you think back to when you were a kid and you go underwater and you're swimming all around, your CO2 is going up pretty quickly and you do feel dyspneic by the end. But it takes a while, right? It takes 30, 45 seconds. Professional divers can go under for many, many, many minutes at a time. And they can control that dyspnea. And so certainly it's a sensation they have. It's important. It's more important than the oxygen. But a lot of my patients with COPD may have elevated CO2 levels. And some of that does contribute to their dyspnea, but it's still a smaller proportion, okay? So what is most important, and then the next is that pump. The pump the heart can certainly contribute to dyspnea. My observation is many times it's more of a tiredness that folks feel, though. It's more just like a little bit of a lack of get up and go than that feeling of, I can't quite breathe, I can't get my breath. They describe it. Now, like we said from the beginning, dyspnea is, there's as many sensations of dyspnea as there are folks in this room and out there in the world. It is a subjective experience. So some folks with heart issues may feel very dyspneic with it, but I'm just talking in sort of generalities and the physiology and how it's been studied and what we found most folks are like. And most folks with heart trouble, they do have some dyspnea, but it's secondary to the feelings of the heart pain or other symptoms they might have. And so what we come back to then is that kick to the stomach of the soccer ball. And this is what I point out to my residents and my interns, is that it's your brain saying, I want half a pedal on the gas, right? So, if I'm breathing fine, if I'm at rest, I'm just barely got my foot on the pedal, right? And I'm just kind of coasting along through traffic. And then, the light turns green, I want to get going, let's say I want to do 30 miles down the road. Okay, I'm going to put my pedal half down, my foot half on the pedal, and I only go 10 miles an hour. And all of a sudden, that comes back. That's those signals, especially from our chest, from all those receptors there. It comes back and says, gosh, you told me to give 50% effort, and I got 5% stretch. I was only able to get 5% workout. That comes right back, and you know it in a minute. And I always kind of say, gosh, remember when you were kids and you were horse playing with your brothers or sisters or whomever, and somebody put that pillow on your face or something. You got dyspneic really quick, right? Like you took one breath, your brain said, I want a big breath. That pillow was like, you're getting a 5% breath out of this. And you panicked right away, right? I remember that. And then everybody's like, no more pillows, right? No more pillows. And your mom or dad would come out and really scold you because it's really scary really quickly. And it has nothing to do with your oxygen, has nothing to do with your CO2 or anything else. It has to do with your brain saying, I want half a pedal on the gas and I'm getting 10, 15 miles an hour out of this. Does that kind of land? And it's really important. And where this came in with COVID was the mechanics of it. COVID was a very different kind of virus in that influenza, a lot of other viruses, when they attack our lungs get stiff pretty quickly. They fill up with fluid, they fill up with inflammatory cells, they get stiff. And that's the same thing then. My brain's saying, gosh, give me a 50% breath, and my body's like, okay, I need to do 80% work because it's so stiff here. I gotta put out 80, 90% work all of a sudden just to get that 50% that you were asking for. That comes right back to me and I go, Doc, I can't breathe very well. I'm feeling really short of breath. COVID didn't change that lung stiffness, especially in those first few weeks of it. Now maybe eventually it causes certain issues for certain folks way down the line. But in those first few weeks of having COVID, those changes in that lung stiffness didn't occur, and so that's why you had folks coming in very hypoxic. They felt fine. They would sort of look at you a little cross-eyed when you say, I'm going to take you down to the ICU because I'm kind of concerned about you, because they didn't have that dyspnea was very mild for them. So I just thought that was a really fascinating part of that experience from my perspective, and really brought back to me something that I hadn't thought about for 5 or 10 years since fellowship and all that. So now one other thing is it's really interesting then. So all these sensations come to us. They're coming up to our brain, and then we've got some pretty cool things. And everybody likes a picture of the brain, or at least I do. I'm a neurointensivist too. And so this is really cool. This is a functional MRI. And really, I just put it up there because I wanted to show you that there are some very specific parts of the brain that are activated, and we call it the limbic system. What that means is this is kind of our fight and flight. This is our fear. This is our pain centers. These are the centers that are activated by dyspnea. And so it's very clear, and we can see that in folks when we put them in these kind of functional MRIs. It's really fascinating. And that's that big part of the brain that's interpreting all this. So I think, again, that soccer ball to the stomach. Well, I guess we'll do questions afterwards, but I think that's a really important, and it's an interesting thing, and I always think it's helpful for me at least, to understand. I'm 47 now, and I have those 47-year-old aches and pains and back issues and stuff, and I now know what that is and where that disc is or whatnot, and so I know how to work with my body that way. And so I think it's helpful to understand those underlying issues. Okay, it's not necessarily my oxygen. I want it good, and I want my CO2. I want to be, moving my breath and doing my pursed lip breathing or other things like that. But boy, a lot of this has to do with just where my mechanics are in my chest and helping that out. And there's different things you can do about that. All right, so we talked about how we feel dyspnea, how we interpret it, and what it kind of means. But I just wanted to kind of go through some causes again. So many of these are pulmonary. Many of these are lung-based, but not all. So on the far right there, you've got MSK, that's musculoskeletal. And so there's deconditioning. That's actually a really important one because it's one that we can do a lot about. And it's one that, as towards the end, I'll talk a little bit more about. But it's that deconditioning. We all know, like, back in freshman year of high school or something, you get to PE and you got to do that first mile run or something, and that's not fun, and that's deconditioning. But with work and with attention, you can improve that. Certainly obesity is an important one. Anemia is important. So every once in a while in lung clinic, we have somebody who comes in and turns out they're just very anemic. Cardiac, of course, and this is always something that we as lung doctors have to keep thinking about when we're seeing folks is they're seeing us for the bellows, for the lungs, and they probably have a breathing problem, but a lot of times that heart and lung can go together. I'm a pulmonary hypertension specialist. That's like my favorite niche, and I've done that for 20 plus years, and so that's in that disease, it's a very tight coupling of the heart function and the lung function, and it causes that fancy, that 50-cent word there, whatnot, cardiomyopathy. That's a big word that actually encompasses a lot of things. That encompasses everything from heart attacks to pulmonary hypertension. It's just a fancy word that says your heart muscle is not quite right. It's just doing something wrong, whether for one reason or another. So the heart's just not squeezing as well. CAD is that coronary disease. That's where the heart muscle is just feeling sore because it's not getting enough blood flow. HTN is hypertension, so in extreme cases that can cause some shortness of breath, and again, that anemia. That's a little different though. This is anemia that's because the heart muscle is not getting enough oxygen, not just sort of just being generally anemic. And then lastly, the pulmonary, so pneumonias, ARDS, all these things are really important. The reason why people feel dyspneic with these things is because they're changing the stiffness of the lungs. Asthma, COPD, those are a little bit different. Those have to do with being hyperdynamic, sort of being overexpanded. So those receptors are already really stretched out, and it's hard. Your muscles just aren't in the right spot for it now. They're just kind of, it's like if you were in the weight room, and one way it's easier to do a curl, but it's really hard to do one out here. It's when you have asthma or COPD, a lot of times if you're really hyperexpanded, it's more like your muscles are out here and you're trying to do that curl. Interstitial lung disease is the exact opposite. It's when that lung is just getting kind of pulled in and stiff. So I wanted to take a second and just kind of help you guys understand how we as doctors kind of think about this and walk through it. So, we want to first look at the lungs. We'll get chest imaging. This is a classic one. I think you guys maybe can appreciate that the left side has more white on it and the right side, the left side has less, it's darker, it's less white, and then the right to you is lighter. And that's a classic sign on chest x-ray of a PE, a pulmonary embolism. And this is a great example of when people feel short of breath because of those cardiac issues, because it's blocking up some of the blood flow there. You might have your doctors ask you to do echoes. That's when we want to look at the heart and how well it's functioning. And we can apply all kinds of different windowing to it, and we can look at your valves and how the blood is flowing. And this, I do this all the time as a pulmonary hypertension doctor. But this is really evaluating that pump portion. PFTs, this is an example of the type of PFTs we do in my office. What we are looking at is really how well you're moving that air through your lungs, how well you're ventilating. And like I said, though, this is a very dynamic thing. Two people could have very similar PFTs but have very different dyspnea because of other issues. The last is this very fancy cardiopulmonary exercise testing. We don't do it in my office. I usually send folks over to National Jewish or up to the university for these. I've done one myself, and I was out of shape. So that was a long time ago. But really what they're doing is it's looking at that mechanism, and it's really looking at the whole thing from your heart to your lungs in a very dynamic fashion. And again, you can have folks who at baseline seem to have very similar lung function, but it's experienced very differently. And there's other kind of, I'll skip this, but what we do is we really look at how much oxygen you're burning, you have this mask on, and you're riding on a bike and all these sorts of things. So with dyspnea, I think this is a really important slide. I always say we as humans are creatures of motion. And this is just an example. It's an older study, but it shows, not that old though, but it shows that folks with COPD who are able to stay active, that top line, that means they're still around in 54 months from when they started the study. But those folks, you can see that were less active, less able to be active, they just didn't do as well. And so it's really important to be able to manage your dyspnea and to be able to stay as active as you possibly can, despite having whatever problems with your lungs or your heart that you might have. And then what can we do about it? I mentioned pulmonary or rehab. I just want to really hammer this home. Pulmonary rehab is next to smoking, stopping smoking, is the best thing you can do. In many cases, if you've got COPD or other lung issues, ILDs, or pulmonary hypertension, exercising, just moving your body. It will help you benefit. And this is kind of I know it's a kind of a crazy slide, but basically what it's saying is, you see how all those dots are above zero? That means that all those folks, they were able to exercise more, move a lot further after participating in pulmonary rehab. And so I always want to plug that, okay? As a lung doctor, it is my favorite thing to talk about. And then there's similar programs and similar kind of really great data behind cardiac rehab as well. So for those folks who have heart issues, there's more cardiac rehabs in town than there are pulmonary, but there are some telepulmonary rehabs as well that I would encourage you to speak with your health providers about too if you're interested. Okay, so they can even send you a tablet and meet you in your office or in your living room or wherever. So, all right. So that's my family, and believe it or not, my hair used to look a lot like my eldest son on the right, but that was a long time ago.
So it's question time. If any of you have questions, raise your hand and I will bring you the mic.
Good morning, Doctor.
Morning.
Thank you so much for coming out and speaking with everyone. You talked about musculoskeletal issues, naming like anemia and whatnot.
Yeah.
Are you seeing more of the postural or orthostatic tachycardia syndrome?
Oh, like POTS.
Yeah.
Yeah. That syndrome typically doesn't come our way as much as lung doctors.
Sure.
It typically will go usually to the cardiology side of things. That being said, it's really important. So I, as a lung doctor, am always kind of considering those cardiac issues along with my pulmonary issues when I'm evaluating dyspnea. And yeah, when folks are orthostatic, that's a word that says when you stand up real quickly, you get that head rush, but it's a little bit more than that, and it's always happening all the time. There can be many reasons behind that. There are some syndromes that are very specific about it, but pulmonary hypertension can cause it too. There's a lot of different things, and so I have a lot of orthostasis in my clinic. It's the pulmonary hypertension kind, not the POTS. Yeah.
Good morning and thank you. I'm both a patient with ILD or fibrosis or whatever it is, and I'm also a pediatrician, retired. And my big issue has been respiratory therapy and the lack thereof in between the hospitalizations, at least in Colorado Springs. My question is this: a lot of us get anemic, or borderline anemia, and obviously hemoglobin, red blood cells are important to get oxygen to what's our primary problem is lack of oxygen, and we need that, and we also then are combating the anemia. When it's worked up, it always comes out as we don't know, can't find the reason, and it's chronic disease. So would you comment at all on, because you brought up anemia in two of your columns, what we can do or what we can ask for to look for it or treat it? And when is it really important? Borderline low or low?
All right, that's a good question. So anemia, the most I usually deal with it is in the acute phase in the hospital, right? And so in the hospital, we have a lot of, it's been studied a lot, and we have a lot of good data, and every time we seem to look at it, that actually our threshold can be very low there, okay? So when you're in a hospital setting, your anemia, we have the hemoglobin and hematocrit. You know, a normal hemoglobin might be 13, 14, 15, something like that. Hematocrit 40%, 45%. You can be as low as 7 on the hemoglobin, almost half, and 21% on the hematocrit. And in most cases, we shouldn't transfuse you at that point, okay? In most cases. There's exceptions, and one of those exceptions is if you're having like a heart attack or a heart issue, we will bump that number up a little bit. But in the outpatient setting, certainly like chronic anemia is very problematic. Unfortunately, it's one of those markers. So a lot of times what we come up in medicine, right, we'll see things that are not great. And then we try to replace it or fix that number, and we do lots of studies, and we don't necessarily find that it's not giving us the benefit we want. And so like, there's a lot of different ways of trying to boost your hematocrit, your red blood cells as an outpatient. And unless you have that deficiency, unfortunately, going to getting on Epogen or all these other things, they're not helpful. They can actually be harmful. So what you need is, you just need a workup. And like you said, sometimes it can be frustrating because if it is just that chronic disease, then we still don't have a good treatment for that. But you want to make sure that it's not a hormone imbalance. You want to make sure that it's not a kidney issue, an iron issue, a vitamin issue, those sorts of things. So I wish I had a better, more satisfying answer for you. But it's not so simple as like your oxygen's low, you need oxygen. It doesn't unfortunately work that way. It's still elusive.
One of the issues I see often is anxiety. A person can maybe have a mild episode of dyspnea, but they begin to panic.
Yeah.
And it becomes so severe where you need to pull that person back and calm them down. Mm-hmm. You didn't put a lot of emphasis on that, but sometimes I think that's one of the main issues. And I know we're going to have a talk on it, relaxation here later today.
Yes.
And I'm sure that'll be addressed.
Yeah, there's actually some really fascinating data around that. So, there's, as a lung doctor, I remember the first time a patient, this is years and years ago now, came to me and, was saying like, what about nasal breathing? And I was like, I'm not so sure. But actually, there's really good data around that. So there are interesting studies that look at this and look at kind of the way that you can breathe, just like inspiration to expiration, so these long sigh breaths. There's the pursed lip breathing. There are a lot of things that you can do, and I don't want to steal anybody's thunder, but there's a lot of actually very real things that you can do that can really help with that feeling of dyspnea from a breathing standpoint, that can help in that mindset. Because, sometimes I always feel like I got to point out to the newer doctors that I'm training, like, you'd be anxious too, like if you couldn't breathe or if this was going on. And so, let's first just make sure that we've, taken care of first principles. Have we done everything we can about the reason before we treat the anxiety, because, with a drug or something, because, we want to address the underlying issue. And hopefully we can do that without a medicine. Yeah.
And he did, I think it was an FEV4, but it was my lung capacity compared to people my age.
Yes.
And he did 2 of them. One of them was 22% and one was under 20%. I'm still kicking, so, I've been working on it, just exercise and keeping busy.
Yeah.
Since then, I asked my primary care physician if I should go see a pulmonologist again. And he said, well, you can, but he's going to tell you your lungs suck. I said, okay. And so I haven't. I already knew that.
Yeah.
Is there any particular value, or do you think I should continue to see a pulmonologist on a regular basis?
Well, gosh, I'd hate to say don't see a pulmonologist. That's what I am.
But I mean,
But,
was there some validity to that?
yeah, so I think that there's some nuances to this, but a lot of primary care physicians take care of folks with COPD or lung issues, and they do a great job of it. That being said, there are, and I can tell you in the last 10 years, there's been a lot of development of different treatments and regimens. And so, I would say if it's been that long, there may be some benefit to seeing a pulmonologist again. But I would have a question in mind, right? If you are seeing a doc, sometimes we have, as the doctors, we have a very concrete agenda, right? We say, gosh, we heard that you had X, I saw it on a CAT scan or I saw it on an EKG or something like that, right? We know that you have this, and I really want to help avoid more problems from this for you, or help fix it for you. So this is my agenda for you as the lung doctor. But a lot of times too, if you have a chronic disease, right, it's more about, we have our agenda, but we also want to hear your agenda. We want to know, what's your dyspnea like? What sorts of things are you able to do or not? And just from what I just heard, it sounds like you're doing a lot of things the right way, and you're exercising, you're staying active, and you're seeing your other physicians, and I assume that they're helping you with other managements of it. And so, if you were to see a pulmonologist, I would say, at least from what I heard right now, I'd say I'd want to know what the question is. I'd say, okay, how can I help you? And then you'd have to tell me.
Yeah,
So
I don't know, my doctor told me to see it.
yeah, okay. Now, the one thing that you pointed out, though, that I want to touch on, too, because a lot of times that number, right, those numbers that we get in the PFTs that I showed back here, these numbers here, they correlate very poorly with, like, survival and all that, to your point, right? So I've had patients who've had very poor lung function, and I've had the honor and pleasure of taking care of them for many, many years. Because those numbers, they don't do a good job of telling us as doctors or as patients what that sort of future looks like for you. They can tell us about other things that are really important, can tell us about exercise or what things might benefit you, but other than that, that they're not going to tell us, they're not going to give us much insight into the crystal ball of, am I going to see the 12th Avengers movie or something like that? So, yeah.
Thank you.
Yeah.
Dr. Hunt, I had pneumonia back in March, and I've recovered from the pneumonia, but I have scarring in my lungs, and above 7,500 feet, I need supplemental oxygen. I'm okay here at this elevation now, but I'd like you to give me some perception of the recovery or improvement in my breathing capacity for the future. What's your perception about how well that can be done?
Yeah, that's a great question. So I'm going to kind of roll that back a little bit into some other kind of data or kind of things that we look at. So there's a form of pneumonia called ARDS. I used that term earlier. That's a very, very, very severe form of pneumonia. And it's when folks are on ventilators, and they can be on ventilators for more than a week. And it can be very devastating at the time and actually quite deadly. But for those folks who survive that very severe form, the question was, to your point, what are their lungs going to look like? Because when you throw up a CAT scan when they're so sick, it's all white. It's all just inflammation and maybe scarring and all these sorts of things. And to your point, maybe some fibrosis or scarring there too. And the good news is, in most cases, when you look a year out, those folks and their lungs have actually healed. They're, from a lung function standpoint, when you just look at these sorts of graphs and numbers and that sort of thing, those folks who had very diffuse lung injury, their lungs have gotten back to their baseline beforehand, but it can take a year. Now, there's other issues when you get real sick, and again, I don't know all the details, but when folks get really sick, there are other issues with their body and just their generalized conditioning and muscle strength. And unfortunately, for those cases where folks are really, really sick, we call it kind of a critical care associated illnesses. Those kinds of weaknesses or just feelings of fatigue, those are more long-standing, but the lung function can very much get back to normal. And so I guess if your illness was, not even quite a half year ago, I think is what you said, so I would still have a lot of hope and determination that your lungs are going to still be going through some healing, okay? The one issue, though, I do want to point out is still in circa 2024, we still don't have good ways of regenerating lung. So I always say, that the lung you've got is the lung you've got. Now, it's the size of, when you spread it all out, it's the size of a tennis court. And a lot of times when we see something on a CAT scan, it may look scary, but it's actually, when you put it down on the tennis court, it's like that big. So not always as impactful to the lungs as you might at first be concerned about when it's just like a discrete pneumonia or something like that. But in your case, I would still be very hopeful that your lungs have some healing and that you have some still recuperation to do even this far out. You're welcome.
I've been diagnosed with pulmonary hypertension, and I've realized that a lot of the pulmonologists are not really understanding this, or that they haven't been trained a lot in recognizing the signs of this. Do you see the residents getting more information and understanding this better as they're going through their medical training, and we're going to have the pulmonologists that can recognize these a lot better, so it doesn't take 2 to 3 years for you to get diagnosed?
Yeah, that's a great question. So it's one of my favorite lectures to give my residents is about pulmonary hypertension, because it is the torch that I love to carry in my medical training and all that. It is, it's still, we talk about delays in diagnosis, right? And depending on the type of diagnosis we're talking about and the rarity and whatnot, there can be sometimes very long delays. And pulmonary hypertension is still, as you point out, in my opinion and in most folks around, unacceptably long, right? It takes a while. Now, sometimes that can still, I always tell folks, sometimes we do have to wait for like a disease to show itself enough to even for our really fancy instruments to show us what we need to see to be able to diagnose it. But awareness is the very first step, as you point out. And so, I think, in my opinion, we're very lucky here in Denver. This is like a pulmonary mecca. This is why many of us, like myself, came from, all over the country to study here and stay here. And, I'd love to give a plug to my mentors, Dr. Bull and Dr. Badish, up at the university. They're fantastic, and they have a fantastic program. I love to take care of pulmonary hypertension, and I do so in the community, and there's other doctors out here as well. But yeah, it's one of those things that as a general pulmonologist, we're taught about it, but it is still, even my partners, they ask me lots of questions all the time, and I talked with them too. It's one of those rarer issues that requires, sort of somebody to stay always on top of their reading and their knowledge, because it changes, and there's new medicines even just the past month or so. There's some new medicine out, and so it's one of those things where it really requires that niche, and it requires, as you said, just folks to have it on the cortex as they're seeing somebody. So echocardiogram. Start with that. So great question. All right, guys. Well, thank you. Thank you so much.